she had that relief from the labor pain. Uh, and historically, this whole story is in the Holy Quran. So it was first used as an ether and chloroform, but they had a lot of issues, lot of complications, so it was not continued. Uh, what is pain? Pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. This definition is given by the International Association for the Study of Pain. That's the standardized definition for all pains. So, but what we are facing in obstetrics, that is the acute perioperative or peri-delivery, peripartum pain. So that is pain that is present in a surgical patient because of pre-existing disease, the surgical procedure, or combination of both. Why to treat pain? That's the basic human right. Decrease pain and suffering. It decrease complication because pain is associated with a lot of complication. We'll see in the next slide. And plus development of the chronic pain. And if you treat the pain, the patient got satisfaction and the speed of recovery, decreased length of stay, and improvement in productivity and quality of life. So adverse effect of poor pain control, it affects almost all systems and organs. Like in cardiovascular, patient may have tachyarrhythmias and MI, and because of pain, the patient breathing effort is poor, so prone to develop atelectasis and pneumonia. And so it almost all systems are affected. So it is very important to treat the pain, especially acute uh, perioperative pain. This is the WHO Analgesic Ladder. That's from the mild to severe pain. So you start from the simple paracetamol, then you add on mild opioid, then a strong opioid. So this is called the WHO Analgesic Ladder. This is the universal pain assessment tool uh, uh, because you have to assess the pain. Is it pain? You start from no pain to worse pain. So you can mark scale 0 to 10. So you have to assess whether the patient is having mild pain, moderate pain, or severe pain. So the analgesic regimen or pain treatment is according to the scale. Uh, what are the physiological changes that happens during the pregnancy? We start with the cardiovascular system. So almost all the changes seen are due to high levels of progesterone and include there's increase in the total blood volume, and increase in the heart rate, there's increase in the cardiac output, there's increase in the stroke volume, and there's this decrease in the systemic vascular resistance. Uh, 500 milliliter per minute blood flow is increased to the uterus, and there's a decreased venous return from legs. Aortocaval compression because the gravid uterus is lying over the inferior vena cava and aorta. Impact of the cardiovascular changes, the patient with the pre-existing cardiac disease may decompensate either during labor or immediately post-delivery. This corresponds to the time of the maximum cardiac output. Approximately 400 to 600 ml loss occurs at delivery. Supine hypotensive syndrome occurs because of the gravid uterus lying over the uh, inferior vena cava. So you need to put a wedge over the below the right buttock so that compression could not occur. You can see the image. If the patient is supine, So by the gravid uterus, aorta and inferior vena cava both are compressed. So if you turn the patient laterally, that will resolve the hypotension. Uh, Physiological changes for that's respiration, increase oxygen consumption, increase minute ventilation, to the decrease arterial PCO2 because of the increased minute ventilation, and there's a decreased functional residual capacity, causing a decrease in the oxygen reserve. Uptake of inhalation agent is faster, decreased functional residual capacity, and increased oxygen consumption, increased risk of hypoxia with apnea. Uh, pre-oxygenation, uh, pre-oxygenation prior to general anesthesia is recommended because the reserve is too low. So rapid sequence induction is performed uh, when while giving the general anesthesia. Airway venous engorgement of the airway mucosa, edema of the airway mucosa, worsening of the Malampati score. That's Malampati score is for the airway assessment. So technically, during pregnancy, it is difficult airway is anticipated. Back of airway changes, trauma to the upper airway with suctioning, intubation, increased incidence of difficult or failed intubation, and requiring small endotracheal tube. Uh, Changes for the CNS, there's a decrease in MAC by 25 to 40%, increased dose of local anesthetic requirement for regional technique, and more rapid onset of neural blockage. Decrease inhalation anesthetic agent requirements, decreased dose of local anesthetic for the same effect, increased risk of local toxicity. So we have to consider these things while handling the pregnant lady. Uh, Changes in the GITs, there's a increased gastric fluid volume, increased gastric fluid acidity, decreased competency of the lower esophageal sphincter. So it patient prone to reflux and acid aspiration syndrome. So we have to take care. We have to take a precaution for preventing the acid aspiration syndrome. So all participants are considered as a full stomach. Uh, Aspiration prophylaxis is recommended for the cesarean section. So zero point 0.3 molar sodium citrate, 30 ml orally is given, and previously ranitidine was the favorite drug, but because of association with the malignancy, now uh, waiting for the. So now cimetidine can be given, and maxilone and metoclopramide 10 milligram IV is given as a prophylaxis. Uh, these are the three stages of the labor from the start of the that cervical dilatation to full dilatation, then delivery, and then delivery of the placenta. The three stages of the labor. Uh, where is the pain coming from? Is pain bad in labor? Analgesic options. So it's really bad. It is considered as the worst pain. So you need to treat the labor pain or labor. Uh, you need to give labor analgesia, and so the the nerve supply from the uterus uh, that from the T10 to L1, and then this is for the first stage, and For the third stage, it comes the S2, 3, 4. So you need to block all these nerves. So there are various options to do that. So previously, there were two local blocks, paracervical and pudendal nerve block, but nowadays not used much. So we have better options. So you can see the nerve supply of the. So you can see this pudendal nerve, paracervical block, but the most common technique is the epidural analgesia. Uh, Physiological stress can cause increased level of catecholamine, hyperventilation. These may result in decreased uterine blood flow, leading to hypoxia and acidosis in the fetus. So that's why you need to treat the labor pain. Factors affecting the pain perception in labor: mental preparation, family support, medical support, cultural expectations, underlying mental status, parity, size and presentation of the fetus, maternal pelvic anatomy, duration of labor, and medication she is on. Ideal labor analgesia. Control pain relief, ease of administration, rapid and profound, consistent analgesia, no effect on ambulation,
सच नानक से
maternal expulsive effort, and progress of labor. These should not be affected. So, first step to painless motherhood. These are the options: non medication, inhalational agent, parenteral agents, and the regional techniques. Non-medication, breathing exercise, auto hypnosis, light music, white noise music, massage, walking, use of tents, water bath. So these are the techniques, the non-medicated techniques used for relief of the pain. And inhalational medication, Antonox. Antonox basically it's the mixture of 50% oxygen and 50% nitrous oxide. And the other option is the low dose isoflurane with oxygen. So advantage is on demand delivery, relatively safe. On demand delivery means when the patient inhales, there is a one-way valve in that circuit. Patient on inspiratory effort, the gas mixture goes in and gives it pain relief. Disadvantage is the efficacy is variable, and plus it causes the nausea, drowsiness, and neonatal depression. 10 years back, it was very common to use these antinox, but nowadays, because of the more use of the regional techniques, it is not used nowadays. So, parenteral medication, we have the option, but just we go through the advantages and disadvantages. So narcotics, mapridine, morphine, fentanyl, tramadol, nalbuphine, these are the drugs available. And what we are having, that's tramadol and nalbuphine. My advantage is relatively good analgesia, but disadvantage is nausea, vomiting, sedation, neonatal depression, and short duration of action. So it's not a good choice. And plus, because of the neonatal depression, at the end of labor, you cannot give these opioid medications. Morphine, uh, the most potent analgesic drug is the morphine, so that can be given as an IV boluses or continuous infusion or patient-controlled analgesia. Patient-controlled analgesia is a better choice because it is safe, and patient satisfaction is more. But at the end of the delivery, it should be stopped so that neonatal to prevent the neonatal depression. So it's a basically it's a infusion pump that delivers a baseline infusion, and on top of that, we can administer the top up boluses. So this that you have to fix the lockout time so that the drug will not go before that, and you have to set uh, the amount of the dose for the bolus given in that time. It is safe, but it needs training and patient satisfaction there. But still, uh, for post-operative analgesia, patient PCA, patient controlled analgesia is good. But for labor analgesia, regional techniques are preferred and very safe. This is the infusion pump for the PCA. Regional techniques, the option epidural, spinal, and combined spinal epidural. Advantages: excellent pain control, minimum impact on progressive level with low dose, less drug transfer to fetus, improved uterine blood flow, decreased birth trauma, for example, use forceps and minimal neonatal depression. Disadvantage: invasive technique needs training, side effects, hypotension, headache, itching, nausea, urinary retention, limited mobility, nerve damage, infection. But these are all uh, disadvantages of the regional technique is very much low with the trained person. So with good training, the regional techniques are preferred method, and they give a very good pain control with very less side effects. Anesthesia and parturient. So patient general consideration for the patient undergoing surgery and obstetric surgery. Altered physiology, as already mentioned, is to the fetus, effect of the disease process, therapies, possible teratogenicity of anesthetic agent, intraoperative effects of vitro, placental blood flow, increased risk of preterm labor or abortion. So these are the uh, risks we have to consider. So altered physiology, altered response to anesthesia, decreased MAC, increased sensitivity to neuroxyl agent, decreased plasma cholinesterase, decreased protein binding, limited drug formation in particles. So you can see there's a decreased dose of the drugs required, and plus because only the used and old drugs are safe, because we have the information from the literature. The new drugs are avoided. uh, Again, teratogenicity, limited information due to the impracticability of conducting trials with a sufficient power. Guideline based on effects of on reproduction in animals, epidemiological surveys, or personal studies of the pregnancy outcomes in parturient undergoing antepartum surgery. So best is to use the drugs which we have already experienced with that. Nitrous oxide has been shown to have a teratogenicity effect on the rats during the first trimester. No anesthetic agent is a proven teratogen in human. Anesthetic agents deemed safe include thiopentone, morphine, mapridine, fentanyl, succinylcholine, and non-reproductive muscle relaxant. So limiting nitrous use only if hypertension secondary to volatiles can be avoided. Anesthetic management in the parturient should be directed to because it will affect the fetus. So avoid hypoxia or hypoxia. Avoid hypotension. Avoid acidosis. Maintain PSO2 in the normal range for the parturient. Minimize the effects of the aortocaval compression. Anesthesia for C-section. So preparation, preventing complication, choice of anesthetic technique, and effects on the fetus. Preparation, if elective case, we ask for the uh, fasting at least 6 hours. And, but for if the patient comes in emergency, then still what we will give the uh, that aspiration prophylaxis syndrome. So that includes the antacid and antiemetic and the cimetidine. So we need a good IV access, fluid policies within 30 minutes operating, avoiding glucose containing fluid, left lateral tilt with a wedge under the right pelvis. So prevent the supine hypotensive syndrome and routine monitors ECG, blood pressure, pulse oximeter. So for if patient needs general anesthesia, then we need entitled CO2 nerve stimulator or temperature probes. Uh, so pre-aspiration prophylaxis, detailed airway assessment, fluid resuscitation, left tilt to prevent hypotension, safe practice for placement of neuroaxial block. Uh, techniques, local infiltration by surgeon, not a good choice. Linear techniques, yes. Spinal, epidural, or combined spinal epidural and general anesthesia. These are the choices for giving anesthesia to a parturient lady. Local infiltration rarely performed. Patient usually in extremis surgery must be done by midline incision, gentle retraction, no exteriorization of the uterus, usually done to supplement to renal technique if local anesthetic toxicity is not a concern. Spinal is for the elective cesarean section. Spinal anesthesia is a elective and emergency this urgent C-section in which obstetrician can wait for the effect of the spinal. So it's a choice of technique. It is easy and simple to perform, rapid onset, single shot technique, profound neural block, technique of choice for uncomplicated elective C-section and many emergency C-sections. This is the uh, landmarks showing for the the test of the ileum is at the L3 L4. So we usually go below L1 for this panel, below L1. So we select the uh, space, and this is the ideal position for putting up the spinal anesthesia. Spinal, or even for the epidural sitting position. The other option is the lateral decubitus position. So for the spinal technique, follow the sterile aseptic technique. Position the patient. Uh, the needle will pass through the skin, subcutaneous tissue, supraspinous ligament, interspinous ligament, ligamentum flavum, epidural space, and the dura. So then you administer the medication. Potential complications: hypertension, headache, backache, nausea, vomiting because of the low blood pressure, and neuroaxial damage. Very, very rare. Anaphylaxis, very, very rare. Epidural, it's technically little difficult than the spinal, so it's more challenging. Slower onset, used when already placed for labor analgesia, used in parturient where a slow controlled onset of labor block is needed allows prolongation of block should the surgery be complicated. So, if the patient in labor already with the epidural, we can continue by topping up the epidural for the C-section as well. Uh, Advantages: superior pain relief, less systemic side effects, lower incidence of deep vein thrombosis and pulmonary emboli, decreased blood loss, intraoperative during orthopedic urology. These are because the epidural used in all these cases, but there's less blood loss and more rapid recovery of bowel function, early embolation, better pulmonary function test, and suppression of neuroendocrine stress response. Epidural technique same. Aseptic technique follows sterile technique, patient position, but here we go into the epidural space. It's the negative space when we cross the that ligamentum flavum, we feel the loss of resistance to air or saline, whatever we are using. So then we insert the uh, catheter into the, you can see catheter into the space, and after securing the catheter, then we give the test dose, and then we give the bolus dose and infusion. So this the anatomy of the epidural space surrounds the dural sac, anteriorly posterior longitudinal ligament, posteriorly ligamentum flavum, laterally paticles, and intervertebral foramen. Uh, AP dimension of the epidural space is largest in the lumbar region, and inferior region decreases, and the space is more continuous. So this is the epidural, how to get into the epidural space. So we use the loss of resistance technique. Then complication: hypotension, headache, transient backache, urinary retention, unintentional spinal injection, intravascular injection of local anesthetic, neurological damage, and infection. So all complication rate uh, uh, decreases with the repeated use and repeated uh, training. So the expert anesthetists, they um, encountered very less complication, but these complication needs to be explained to the patients. Combined, when there's a chance of uh, prolonged duration of surgery, so and you need a immediate block as well, so we can combine the both spinal and epidural. So we give the administer the drug intrathecally or spinal, so that quickly we can start the surgery, and then we give the continuous infusion or boluses for uh, uh, prolongation of the surgery. So this is both spinal needle uh, is the drug is administered intrathecally to the spinal needle, then needle is taken out, and then the catheter stays into the epidural space. So then the patient controlled epidural analgesia. So it is basically epidural analgesia, but the infusion pump is modified with that software that the patient controlled epidural anesthesia. So there is a control button is handed over to the patient. So if patient feels pain, she can push the button to deliver the bolus. And there's a baseline infusion is also going on. So technically, that allows basal infusion and demand bolus into the epidural spaces, and the drug used commonly is the bupivacaine uh, for pain, it is 0.05 to 0.125, and but for the anesthesia we give the 0.5%. So, but it is for the analgesia, so this dose 0.05 to 0.25% we can mix with the opiate, fentanyl or hydromorphine or morphine can be used. Uh, Contraindications for the renal techniques, the absolute is the patient refusal, consent is mandatory, and if the patient is coagulopathic, increase ICP, or local skin infection. So it's difficult to cite the regional spinal epidural if the back is infected. The relative contraindication, patient is uncooperative, neurological disorder, anatomical abnormalities. Advantages of CSC, combined spinal epidural: rapid onset of intrathecal component, better COX, intrathecal medication devoid of motor block, so walking epidural can be administered, atraumatic spinal needle, less PTPH, that is post-dural puncture headache. That is the headache occurs with the if the hole is bigger in the uh, so there is CSF leak and low pressure headache. So epidural catheter is there for the supplemental analgesia, and epidural catheter is there for the surgical anesthesia if required. Complication of the epidural analgesia: failure of block, injury to nerve, infection, epidural hematoma or abscess, dural puncture. Dural puncture may cause total spinal or post-dural puncture headache. But these all complications, uh, it's much less with the expert hand. So training is basically that helps you for the that minimizes the complication and maximizes the use of the techniques. Uh, Side effect of the drugs in the epidural space: hypertension, intravascular injection, local anesthetic toxicity can occur, respiratory depression, sedation, bladder distension, and difficulty in ambulation. Ideal labor analgesia for mother: fast, effective, continuous analgesia, mobility, and second stage pushing. For obstetrician, no effect on labor outcome. For neonatologist, no effect on neonatal outcome. So these are the uh, ad- advantages of the uh, epidural techniques for and it is beneficial for all anesthetists, the patient, mother, baby. So all the above, what we have advantage, all the above, no side effects, less complications. Anesthesia used when the patient refuses and regional technique, and when the regional technique is contraindicated. For example, coagulopathy, for example, that local sepsis. So, and there's this emergency C-section and not much time to wait for the effect. So, uh, gen anesthesia is given. Complication: failed intubation, failed ventilation, awareness, aspiration, pneumonia. So that is why renal techniques are preferred, and general anesthesia is used when uh, indicated, when it's when the renal techniques are contraindicated or there are issues or problems with it. So, but we have to consider all these problems for the safe outcome. So the same: avoid hypotension, hypoxia, acidosis, hyperventilation. Limit time between uterine insertion and delivery to less than 3 minutes. So medically it should be documented. Skin incision, uterine incision, baby delivery. So if it is baby is delivered in time, so there's not much problem with the general anesthesia. Infants exposed to GA have a low Apgar score at 1 minute, but no difference at 5 minutes. So there's not much difference with the GA if administered appropriately. So I will end my uh, tutorial by concluding that there is a need for acute pain service team and procedure specific post-operative pain management and encourage